Now, talk about incentives on this. Some companies are starting to do this now in significant numbers with hearts, backs, neurological diseases, etc. And they're at the stage right now where they're saying if this works, then they're going to put teeth in this pretty soon and say, this is where we're going to pay for it. I know about 6 or 7 companies have already said the only way we're going to pay for this procedure is if you go here and do it, and you're going to have to get on an airplane to get there. You can go anywhere you want, have it done anywhere, but we're only going to pay if you go here, period. I was in the early days of PPOs. They all start off incentive-based. 5 years later, they were disincentive-based. 15 years later, they were EPOs. This is going to follow the same track, except it'll happen in 5 years. It is entirely possible for a company to get started on this aggressively and have their benefit cost 10 or 15% lower in 5 years than it is today, by doing nothing more than helping people get the right diagnosis and avoiding people getting life-threatening surgery that can't possibly help them. An HR executive at the biggest bank in the world heard me give a presentation on this, came up to me afterwards, and he said this is what he would call a trifecta of goodness. The employee, waive the deductible and copay if they go to one of these places. He says the employee saves money, the employee gets better quality care, and the company saves money. What's wrong with that? I say nothing's wrong with it. Companies have been doing this and doing this stealthily for 15 or 20 years. Nobody wants to put their names up on a marquee and say, we're the company that says you can only have this surgery done here in this state, but this has been going on for a while. They're starting to become a little bit more visible with it. People were afraid earlier that they got too visible with it, they're going to be called up for congressional hearings or whatever, or get real bad publicity, but it's been going on for a long time. They're coming out of the closet now. Interestingly, we have all this health reform pending. In the UK, I showed you this chart earlier. They spend about 40% of what we do per capita and half on GDP. They want to privatize the system. So they said they can't afford to spend 8% on GDP, and we're spending 16% of our GDP on it. I noticed before lunch, I did this a whole lot faster than I ordinarily do. I try to talk fast, but sometimes my mouth gets ahead of my brain, so that's a risky venture. If that happened today, I apologize for it. Any questions or comments or advice about this presentation? Yes, sir.
Well, the key is always, how do you identify the best practice providers? So what are your key sources of recommendations?
How do you identify the right providers? It'd take a while to explain that, but partially it's how the doctors are paid. The best care in America going on today is where doctors are fully salaried and accountable. Also, when you send somebody to one of these places, they're examined by a team of doctors, not just one, because nobody ever has one disease. An example of excellence in orthopedic surgery is a lot of people will pop up. Let me back up. Everybody in America has backaches. If we carry a chart, 90% of us would have a backache during the year. Sometimes somebody's had a chronic backache for 20 years will pop up and want surgery. In a very high percentage of the cases, their back hasn't gotten any worse, but their pain coping mechanism has been compromised. The very best places, before they'll do a spine surgery on someone, we'll have them examined by a psychologist to make sure it's not a temporary pain coping problem. And what causes a temporary pain coping problem? Loss of a job, divorce, bankruptcy, home repossession. Your oldest kid goes to prison. Major depression. You go through a period of major depression, extreme stress, you can't cope with pain the way you used to before. One clinic I heard about hired a psychologist to examine all the patients before they did back surgery on them and fired them later because most of the patients didn't need back surgery, were having temporary. So and the ideal is, look, you have to look at things like that, how they approach those kinds of things. Are they examined by a team? Do they have the right screening mechanisms in place? What some people need to present for back surgery, they need to be on Prozac. Get through the situation, the trigger event that caused it, then have them come back in a year later. If they still need it, then they get it. But this will eliminate about somewhere around 30% of them just that one mechanism alone. And I would never send anybody to a place that doesn't do that kind of screening. We're in the process of developing a list of the hospitals. There's also triggers of what you should look for as the place not to send anybody. And I'm gonna stick out my neck, but academic medical centers have real problems in America today. They've got 3 missions: teach, research, and patient care. Sometimes the first 2 conflict with the third one. If you look at large amounts of population data on academic centers compared to freestanding, now Mayo Clinic and Cleveland Clinic have teaching programs, but they're not a government-based institution. This is a university of, it's a government institution, and I've seen real serious problems with those, partially because of the teaching. It's hard to say. I had a doctor call me one time, wanted to do an emergency heart transplant on one of my folks. I said, well, you can do it if you want to. We're not going to want to pay for it. They go to the Mayo Clinic. The doctor said to me, if you put him on a plane to the Mayo Clinic and he's going to die as soon as they pressurize the cabin, I'll let the family sue you personally. So I had my secretary call the guys. We got really lucky. She got him on the second ring. He said, fly. I thought all the time, I just got off a plane. I can fly. Flew out to the Mayo Clinic. He had a blocked artery. A perfectly healthy heart, a mildly blocked artery, got a stent, went home and lived happily ever after. Probably saved his life, and it saved about $1.5 million in expenses. I pulled a heart and lung out of a mid-Atlantic teaching hospital one time. Same situation. They said, this person can't travel, blah, 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 blah. Got him up to the Mayo Clinic, and they needed neither a heart nor a lung transplant, left with no surgery. Not a very pretty picture. So I'd say right now in your benefit plans, you could be paid, as many as 40% of the transplants you're paying for should never have been happened on the patient. I don't know if I answered your question. I kind of forgot what it was, but yes, ma'am.
I guess I was going to ask you, you're talking about picking the right providers. Is there any other strategies you use, like at Walmart? What else did you do? Did you get the credibility from the employees that you wanted to have, or were employees skeptical that their employer is trying to, intercede with their doctor?
Well, for these types of programs, there was a little bit of that. But I'll tell you, sometimes I've just said, look, we'll pay our expense, fly up there and get a second opinion. And I had never had anybody out of thousands of cases ever said they wouldn't at least do that. And I only ever had one, once they went up to one of these places, said they would still want to go have their heart transplant at Amarillo General. I mean, if you've ever been to one of those places, that's what you wish the care everybody in America could have. It is just absolutely fabulous. That's why when you go there, there's these private jets from all over the world. It's because if you're a billionaire in Switzerland or a billionaire in China, you can go there for care. So the experience there is really terrific. And some people want to have these things done locally, but they can be. There's ways to persuade them. That's why in some cases you're just, for certain types of things, you're just going to put in time. And companies are already doing it, saying, well, this is the only place we'll pay. You're happy to have that anywhere, but we'll only pay if you go here. Other questions? Yes.
So some of these solutions are workarounds. So to fix the infrastructure of this, would it be not paying fee for service, having insurance companies be more proactive with questioning and getting second opinions and things of that nature? Because we're not going to have all physicians become salaried. So, what's the long-term solution from an infrastructure perspective?
Well, the second opinion question, let me address that first. We tried second opinions a long time ago and it failed because you're having one unethical doctor doing a second opinion on another unethical surgeon.
Well, I mean,
But you have to get them, and that program failed for that reason. If you get them to the right places, like Cleveland Clinic, even their chart reviews there, they're going to find the same kinds of data I'm talking about here. It's easy to identify the people. Your case management can do it. Your disease management vendors, they can identify those cases, have them go through that second opinion, at least make sure they get treated for the right things, and then identify them. The companies are doing it in a way now. It seems daunting if you've never thought about it, but all the companies that are represented there, you have people getting on a plane and flying somewhere every day. Some companies use their own company travel department to make the arrangements. Hotel, get them there, get them back, give them a credit card to use, etc. Prepay all their expenses. Say to eat all your meals in the hotel. Anything you need to buy in the hotel will be charged to this credit card. So it is works around. But I tell you, there's some hope on this because a couple of clinics are converting to be salary because they see the future of this. And they know they can't keep doing what they've been doing and survive the healthcare spending tsunami that's coming in the next 15 years. And that's one reason why I was just thrilled with what Highmark's doing. They're protecting everybody in Western Pennsylvania, about 40% price hike on this stuff. And you remember she said we've been raising prices all along anyway. Well, I can tell you that's going on by that ventricular assist device example. Any question, any advice for me? Comments, questions? I try to wrap up early because I'm the speaker before lunch, so I intend not to run over. Yes, ma'am?
I'm curious if you see any opportunities for benefit design connected to this beyond the second opinion program that you referenced. I know there are some countries in the world that utilize what they refer to as evidence-based benefit design, where there is a care pathway, diagnostic and treatment care pathway you're supposed to go down. And if you're on that path, you get your care covered. If you're off the path, you don't.
Yeah, I think there's an abundance of that, and that kind of experimentation is starting today in real time. For example, if you have certain types of conditions, I'd tell people before we're going to pay for this to be done anywhere, you have to have this type of second opinion program. The other benefit design is to catch them after they had it, to persuade them that they don't have to have this bad surgery, and then a plan design to incentivize people to present. What Lowe's did is they told their folks, if you need a heart surgery, waive your deductibles and copays, and they're mainly self-identifying. They're calling up saying, yeah, I have to have one of those things. How can I save $3,000? So there's an abundance of that going on today. Good question. Well, thank you for listening to me today. It's been a pleasure being here. I think the presentations this morning were terrific, and I'll be around some over the next day or two to chat with you.